Good evening, students. Today we'll be discussing about rapidly progressive dementia, and it's a very important topic for all the students. And the lifelong learning in neurosciences through Neuro E Pathshala is about to finish 1 year, and we have already did about 45 sessions since last March. Like to continue to support the neurology students who start their neurology education with important topics. They are proposing to bring in a series of lectures on neuroelectrophysiology, because when I checked with some students, there was a difficulty in understanding nerve conductions and EMG studies. So we'll be starting those very soon, and I hope you will patronize the classes so that we get more interested in conducting these sessions. Okay, so the definition of rapidly progressive dementia, as brought out by Dr. Jashwin, is that symptom onset to dementia less than 2 years, typically over weeks or months. And there are many infectious etiologies, autoimmune causes, prion diseases, and neurodegenerative diseases which have got a propensity to develop rapidly. So this talk in will restrict ourselves to prion diseases and as well as neurodegenerative diseases, and so we'll continue with our exercise in this coming classes or infections and autoimmune causes. We already had one class on autoimmune diseases earlier. It's available on YouTube, and one can go back. So next time we'll have a class on autoimmune causes for rapidly progressive dementia. A month ago, we had discussed about current concepts in frontotemporal dementia. Now we'll have some revision part on that also in this lecture, and we have about some 10 to 15 questions, which if some people join and they respond, it will be nice. Otherwise, we'll revise the topic concerned with the question in 1 or 2 slides. So, the clinical pathological correlations and dementia. When a patient comes to us with problems in speech expression and problems in spatial abilities, and if he is overtly no prone to rituals and compulsions, and there is a problem in executive functioning and multitasking, loss of motivation, loss of empathy, there may be hyperorality, hypersexuality, and there is a disinhibited judgment, the disturbances in episodic memory, and other language functions, speech comprehension problems, words and objects, and of course motor weakness and loss of balance and bradykinesia, etc. So we know where the problem is, but not what caused it. That's the whole problem. So that for that we have to equip ourselves with some background knowledge, also some anatomical and physiological understanding of the causes of clinical pathological correlations. So we know that etiology of rapidly progressive dementia has vitamins, that's a mnemonic. Now it is changed to DDD vitamins. The vitamins are vascular causes, infections, toxic metabolic, autoimmune, metastasis, iatrogenic, neurodegenerative, and systemic. All these things can cause rapidly progressive dementia. But now we have added developmental causes, demyelinating, degenerative, vascular infections, toxic and trauma, alcohol, drugs, medications, inflammatory and autoimmune, neoplastic, and systemic seizures and sleep disorders. So many of these things also will cause. Uh, so you should remember this mnemonic. If you are asked to narrate and you have to work up cases in wards or in OPDs, you should keep this mnemonic uh, at your no, tip of the tongue. So, in one study of rapidly progressive dementias and diagnosis subjected in UCSF for Memory and Aging Center from 2001 to 2015, you see non Jacob Creutzfeldt disease constituted 44%, sporadic Creutzfeldt Jacob 29%, potential of 3%, a genetic disease and they are at risk is 1%, and 14% are genetic mediated and mutation negative, but still the genetic is 7%, and variant GCD or acquired GCD is 1% in 622 cases which they studied over 14 years. So this is the in general and this is the background. So we in this talk will discuss only on prion diseases and neurodegenerative diseases in the form of question and answer that I'm afraid that not many people are there to answer the questions, then I'll have to answer myself. If people are there, then we can answer. And let's see, there are no participants who have come. Dr. Sinha is there, and but I think it's a discussion between me and Dr. Sinha, and that's nice. Nice to welcome, sir. Welcome, Dr. Sinha, sir, and we'll see how we can take it forward. So, in prion diseases, human prion diseases are sporadic and maximum, that is 85 to 90%, and that's called Creutzfeldt-Jakob or Jacob-Creutzfeldt disease. The history behind the change of the names, but we don't go into that. That constitutes about 85 to 90%. The genetic causes 10 to 15%, and though 50% have no family history. These are three familial JCD or CJD, Jesman-Stroessler and Schinker disease GSS, and fatal familial insomnia. The acquired ones are Kuru, variant JCD, and iatrogenic, that is dura mater grafts, and because of human growth hormone derived problems. What happens is the prion protein, and prion protein is this is the sporadic one. The tertiary structure of the protein is changed in this. So as a result, the cell is occupied by, suppose if it invades the protein of one cell and it takes over the cell function, and lots of these sporadic the abnormal proteins, unfolded misfolded proteins take over the cell functions, and they propagate in an exponential fashion and cause disruption of the cell function. So these are basically prions, and nowadays many diseases are also thought to be prion like diseases, and those diseases are prion like, but they are not prion diseases. So we will concentrate only on real prion diseases. The sporadic CJD, the peak age of onset is about 55 to 75 years. We'll learn about the radiology findings also. The median age is 68 years, and mean, if you look at 61 years. After diagnosis, survival is 7 months, and less than 90%, less than 1 year in 90%. But one point is there, by the time you diagnose CJD, it is already has taken two-thirds of its course. The incidence is about 1 to 1.5 million per year. Therefore, annually there are about 6,000 cases worldwide. The lifetime risk of dying from CJD is 1 in 9,000. So these are the statistics that are available. Let's look at a case. A 61-year-old person presents with a 3-month history of confusion, forgetfulness, vision, and word finding difficulties. First month, he developed confusion in the house. He had trouble with reading, and it had trouble with using computer. There were word finding difficulties, visual distortions. He felt his hands were too big, and because of these problems, he stopped driving also. The second month, the echolalic speech has set in, repeated what others said, improvisation, non-fluent speech. He stopped cycling, the mistaken utensils use, and he was unable to help with the household chores which he used to do. By third month, he could not be left alone because he was easily angered and frustrated because of his disabilities. So, this individual who was aphasic and right arm dystonia and LVF abnormalities and right alien limb. The MRI has shown DWA and ADC problems, and you can see the cortical ribbon signs that are seen in this case. This is a characteristic feature. There are many mimickers of this disease, but this is one. and this is a case which, to understand the disease, we started with this case. The second one is a 66-year-old lady with primary progressive aphasia for more than 1.5 years. The word finding difficulty and anemia was noticed in and of years back. Slowly, comprehension started impairing, and she could not understand long sentences, and but the fluent part also has got affected. Still, she was biking, kayaking, and driving truck for the work. So some aspects are preserved, the others are not. So this case also has this MRI finding. So what is the important diagnostic test for prion disease? We will see. So what is the diagnosis in the case? Is it a primary progressive aphasia due to Alzheimer's disease? As PPA due to frontotemporal dementia, PPA due to corticobasal ganglionic degeneration, PPA due to Jacob-Creutzfeldt disease, and semantic variant FTD. What is the most possible? If you look at these things, and since the participants are not willing to join, then we'll have to answer. Sinha sir, what do you think the cause could be? Uh, I think then we'll discuss this. This is a clinically a case of Creutzfeldt Jakob disease. She passed away from pathology proven
Yeah.
definite CJD after 2.5 years course. So that's a case, but this is only an example case. We'll have more of them. See, prions can accumulate in occipital lobes, causing visual symptoms. Parietal lobes cause visuospatial problems, neglects problems controlling movement. Temporal and parietal lobes will cause aphasia. Limbic system is amnestic disorder. The frontal lobes, behavior, personality, psychiatric syndromes. Basal ganglia, the movement problems, cognitive slowing, personality changes, and if prions enter thalamus and hypothalamus, then you have pain syndromes and sleep disorder. So it's a great mimicker. You see that CJD is a great mimicker, as you see in the course of the lecture, and it can attack any area. The difficulties and what are the clinical issues in the diagnosis of CJD, if you look at it, diagnosis can be very difficult. Some tests are not very sensitive or specific, confused with other prominent neurological conditions requiring quick diagnosis. Pathology only definitive diagnosis. Biopsy is invasive and maybe falsely negative also, because as you see in one case, and the biopsy did not yield the result. So its sensitivity of the biopsy is 86% in UCSF study, but it usually is about 40 to 60%. But always get biopsy if it's possible, whatever what it is. So what are the diagnostic tests, best ancillary diagnostic tests for CJD? If you look at this, is it 1433, CSF total tau, CSF neuron specific enolase, on RT-quick or EEG, and MRI flare, MRI diffusion weighted, and ADC sequences? What is it? CSF 1433, MRI diffusion weighted with ADC, CSF Artiquick or MRI DWA ADC, or CSF T-tau MRI flare. Sir, anything, any idea?
I
Which
think the
one?
CSF 1433 has higher sensitivity. I don't know what is the latest because the imaging thing can only give you an idea. It doesn't give you a diagnosis. But
Yeah, so,
1433
but
is
the
important, I
study,
feel.
let's see, so the studies have proven otherwise. So, as you see that they have studied a lot of cases. Case of Artiquick on MRI, DW, and ADC. That is the
Mhm.
correct answer for this, and I'll show you why it is.
Okay, great.
CSF 1433 is a very non-specific. It can be seen in many diseases, as I'll show you.
Okay.
Total tau, neuronal specific enolase. Arctic Quick is a new test, and we have three diagnostic criteria now for prion diseases. But the most important for our use is DW and ADC of MRI, as per Dr. Jashwant. So these are the three diagnostic criteria. The WHO revised criteria of 1998. If you look at them, dementia with two of the four following: the myoclonus, pyramidal and extrapyramidal, visual and cerebellar, akinetic mutism, and typical EEG or CSF 1433. No other condition to explain. This is a earlier criteria. Jashwin has stated in 2005 that he just separated visual and cerebellar. He said myoclonus, pyramidal, extrapyramidal, visual, cerebellar, akinetic mutism, but he brought in other focal signs, neglect and aphasia, etc., plus typical EEG or MRI, diffusion weighted and ADC. He removed CSF 1433 in 2005. The Europeans have brought the European criteria in 2009, which were updated in 2017. They say dementia, two of the four following myoclonus, pyramidal, extrapyramidal, visual, cerebellar, akinetic mutism, and typical EEG or CSF 1433 or RT quick. MRI,
All
high
three.
signal in caudate and putamen are more than two cortical regions, temporal, parietal, occipital, but not frontal on FLAIR and DWI. So this is the latest and it has been tested in a population how robust these criteria, and they have constructed the sensitivity and specificity, which I'll show you in the next slides. And so describe the easy findings in the CJD that most of us know. So classical ease is periodic, one cycle per second, spike and wave discharges as shown in this EEG. And what is the diagnostic utility of CSF 1433? As Dr. Sinha was saying that he would like to do this because, and but surprisingly, it is not specific. There are many diseases in which a positive value may be seen, including metabolic encephalopathy, and importantly Hashimoto's encephalopathy, rapidly progressive encephalopathy, unspecified but non-GSD, dementia with Lewy bodies, Alzheimer's disease, frontotemporal dementia, paraneoplastic disorders, malignancies, etc. can be seen. And so, what are three important biomarkers in CSF for diagnosing CJD? And which CSF biomarker is best? That's if we look at that. And any guesses, sir? Important biomarkers in CSF for diagnosing CJD. So let's see. The ROC curve analysis of three CSF biomarkers, the T tau is the best. This is the Foreigner et al. In neurology clinical practice, and they have studied sporadic CJD of 57 cases and non just CJD of 41 cases. And you can see if they have tested 1433 neuron specific enolase, which is positive if it is more than 35, T tau positive more than 1200 picograms, all three and any three. You see, T tau is the best out of these. But when you add radiology to this, then you also have this new test with us now, real time quaking induced conversion assays of CSF and olfactory mucosa, which the sensitivity is about 60 to 92%, and olfactory mucosa is 95 to 100%. The specificity is very high. If it is positive, means it is positive, that is 100% almost. So this also has entered the armamentarium of the diagnosis artiquick. So the CJD diagnostic criteria, European, and which were revised in 2007, has said that MRI has become an important in this. So I'll show you in the next slide what is the MRI findings of CJD. The MRI is, there are mainly three patterns, both cortical and subcortical in 65%, and 33% have got isolated cortical ribboning without subcortical abnormalities. 2% have only cortical ribboning. So these are the three main patterns that are seen in the rapidly progressive dementia in prion diseases. And if you look at this, these are the main three patterns. The cortical ribboning, which is seen, and you can see the gray matter and the deep gray matter and thalamic regions and basal ganglia are also involved, both cortical and subcortical. And you can see reduced diffusion in sporadic CJD. If you look at this, these are the areas which have got reduced diffusion in sporadic CJD cases in 37 subjects, and you can see the areas which are not involved, but mostly they are involved in the basal ganglia and thalamus, deep cortical regions. So the ROC curve analysis of CSF biomarkers with and without MRI, MRI better than any biomarker. That means DWI with ADC map has got a very big sensitivity and MRI included. You see the analysis 0.97. So we are now mostly dependent on this for diagnosis, and they have also studied How many percentage of MRI reports in the US and UK are correctly identifying the CJD? You will be surprised. Many radiologists don't know. They have the answer is only 25 to 50%. UK study 47%, USA study 36%. That means more and more the radiologists are supposed to learn the art of identifying CJD on MRI. We are now having more faith as per the study's current understanding. The misdiagnosis of radiological misdiagnosis happen in 134 cases, ischemia 30%, encephalitis 13%, toxic metabolic about 12%, and encephalitis viral 7%. So, like that, there are many causes which they have diagnosed except CJD in these cases. So that's the status of MRI in diagnosis. Now, 61-year-old lady with morbid obesity presents with 8 months history of insidious symptoms. The prodrome is depression, anxiety, anorexia, 40% weight loss, abdominal pain, etc. Then rapidly progressive dementia. There is a significant past medical history, obstructive sleep apnea and osteoarthritis. The CSF 1433 and T tau is present. MRI is abnormal. So, what could be the diagnosis? This is the abnormal MRI which is shown here, and you can see the cortical ribboning and some hyperintensities in thalamus also, and you're seeing some hyperintensity here. So, next, so, what is the diagnosis? Is it acute nasopharyngitis, non-convulsive status epilepticus (CJD), Wernicke's encephalopathy, Whipple's, Wilson's, vitamin B12 disease? This case, which was diagnosed subsequently, is an eye opener because the differential diagnosis of CJD is so immense. It's a case that is in the literature. It is Wernicke's encephalopathy, both clinical and pathological. There are many cortical and subcortical mimickers of CJD. In That's why the diagnosis becomes very difficult. This lady after death has been subjected to autopsy and the confirmation was done. So there are some mimickers, radiological mimickers of hyperammonemia, and this is a type of picture you can see in hyperammonemia. You can also see it in the post ictal phase also. Some of these things will happen. You can see the next, these are post ictals. They also look like a cortical ribbon, and this is a radiological mimicker of CJD. And some cortical hyperintensity like Wilson's disease can appear, as I showed you earlier, one MRI, and where you have seen the hypermetabolism or diffusion abnormalities. And the extra pontine myelinolysis also is a great mimicker, subcortical region, extra pontine myelinolysis, which you can see also is a great mimicker of this disease. So, what is the differential diagnosis of CJD? If you look at the differential diagnosis of CJD, and any uh, anybody wants a Pramod, you would like to answer? What is the differential diagnosis of CJD? So this is a very, very large difference. Top 10 individual misdiagnosis for CJD, Patterson et al. In 2001 archives in neurology, viral encephalitis, paraneoplastic disorder, depression, peripheral vertigo, Alzheimer's disease, stroke, dementia, central nervous system vasculitis, peripheral neuropathy, Hashimoto encephalopathy. So the observation is that sporadic CJD patients are two-thirds way through the disease course before diagnosis is made. That's why they already suffered that much, and 90% of them after diagnosis will live only for less than 1 year. Look at this case. 20-year-old with a history of depression develops personality change in September 2019, depression in December January 2020, ataxia in April 2020, chorea in May 2020. Which diagnostic modality is best depending on what we learned so far? CSF 1433, total tau, RT-quick, flare diffusion weighted ADC brain MRI, EEG, body PET and CT. Sinha sir, what will you say now? Which one you should? So, as we understood already that
Mm.
MRI is the best. Flare DWI and ADC brain MRI will give us the correct answer about this. What are the characteristics of variant CJD from sporadic CJD? The variant CJD which has come up of late, and I mean, in the subsequent years, in the couple of decades back. So these patients are younger. They are teens, that is, median age is 28, and they live longer than sporadic CJD. About 14.5 months is the median survival. Symptoms may overlap. There are some differences. EG and MI are generally different genetic susceptibility. Pathologically, they're looking directly at brain tissue. There are difference in PRP glycosylation and prion type. Distribution also is there is into lymphoid tissue as well as central nervous system. And the main problem is risk of transmission of variant CJD is very great. 3+ cases transmitted by blood transfusion itself. So the transmission is very high in variant CJD, and you can see the pulvinar sign, which is characteristic of variant CJD. And pulvinar sign can be there in others, but whenever you see this, you can keep no, this in mind.
This
This particular,
pulvinar sign is also there in Wernicke case.
yeah, it is there. That's why that other case we got.
Mm.
No, we have the pathological basis. So the pulvinar sign is seen characteristically also in CJD. So the algorithm for evaluating suspected rapidly progressive dementia, which we defined as that the progression of symptoms in less than 2 years, as by Dr. Jashwind into the so initial screen, second tier workup, rule out vascular, infectious, toxic, metabolic, autoimmune, malignancy, iatrogenic, neurodegenerative, systemic seizures, and if CSF and brain and body imaging findings are not diagnostic, if infection and lymphoma are ruled out, then you try steroids, and that's what is the one which you have to do brain biopsy. And this is an important aspect which we have to concentrate. So conclusions about CJD, I can say CJD is a great mimicker. It can look like anything, and vice versa also. Verify the time course. Often symptoms begin earlier than record states, because by the time you see the case, two-thirds of the disease course is already over. Do not forget the basics. Common things are common first. Be thorough. Try using the mnemonic vitamins. If diagnosis is not clear, get body imaging with or without contrast, PET, CT, and brain MRI. And that's very important, as we studied. Read your own MRIs. Most CJD cases will have DWA positive cortex cortical ribboning that has been missed. CSFs include IgG, OCBs, VDRL, autoimmune antibodies, and you have to look for flow cytometry analysis if cancer is suspected, and of course biomarkers 1433, T-tau, NSC. More evidence you accumulate for your diagnosis. Consider autoimmune etiologies, which we have covered in one of the classes. We'll cover in future classes also. CSF IgG index and the OCBs, serum CSF for autoantibody testing. And don't forget Hashimoto's and paraneoplastic, VGKC complex, GAD, and encephalopathies. Diagnose infections and tumors early for potential treatment. When in doubt, admit for quicker, more thorough workup. So these are the conclusions about that. This is a part 2 of my talk, will be on rapidly progressive dementias with neurodegenerative etiology. It will be interesting if one can answer the questions. We know that the rapidly progressive dementias of neurodegenerative class include the MCI, AD, Alzheimer's disease dementia, DLB, Parkinson's disease dementia, the behavioral variant FTD, primary progressive aphasia, the Cortico-Bessel syndrome, and Richardson syndrome, or PSP and posterior cortical atrophy. They all look like our long-term diseases, but they have a propensity to progress very fast, as you see in some of the cases which we are going to discuss. And the diseases are same what I said, but there may be erythrophilic grain disease and FTD with Parkinsonism linked to chromosome 17. The last class about a month ago we discussed frontotemporal dementia in detail. That's available on YouTube. You can go back. FTD ALS, FTD ubiquitin, TDP43 positive inclusions, and first positive inclusion. So these are the various groups which can progress very fast. So the frequency of neurodegenerative etiology in rapidly progressive dementia has been studied from 2008 to 2009 and 2009. You can see that The frontotemporal dementia leads about 20 to 30% cases, though others have a lot of other studies also. But you see that there are certain percentage of cases, 10 to 30%, who will almost rapidly progress within 2 years. To So the primary neurodegenerative disorders among RPDs are Alzheimer's disease, DLBs, frontotemporal lobar degenerations, corticobasal degeneration, and PSP. Why we should know is, no, this is the era of proteinopathies, and a lot of treatments are being developed against anti-tau, and of course Alzheimer's disease also has got the amyloid therapies, and there are so many of them are in research arena. Or so we It is very exciting field to study. As I said earlier, clinical diagnosis tells us where but not what, and we have reviewed all these symptoms. So the this could be primary progressive aphasia, the behavioral variant FTD, Alzheimer's disease, DLB. So we have to now come to a conclusion. Because we, as I said, the proteinopathies, the proteins that are accumulated and the misfoldings that happen, so there will be in Alzheimer's disease, it is plaques and tangles and TDP43, alpha synuclein pathologies and cerebrovascular disease. The main problem with Alzheimer's disease, amyloid angiopathy with it can make it really progress very fast, and alpha synuclein pathologies again in diffuse Lewy body disease, and tauopathies of PPA and behavioral variant FTD has these protein accumulations, protein inclusions. So why we are learning is there are protein targeted therapies now. Anti-tau clinical trials for PSP may shed light on Alzheimer's also and other diseases which are in progress. And Alzheimer's trial supports beta amyloid origin of the disease, and there are more and more interesting studies are being developed. So if you look at the FTD, behavioral variant FTD, social disorder with executive more than memory and spatial impairments, primary progressive aphasias, progressive isolated language disorder, corticobasal syndrome, frontoparietal syndrome with asymmetric extrapyramidal features, and apraxia, which is very, at times difficult to diagnose, as you can see in one of the cases which we have, and progressive supranuclear palsy, axial rigidity, postural instability, supranuclear disease palsy with varying cognitive and language and behavioral problems. See, the neuropathology is in FTLD, frontal temporal lobar degeneration, is mainly TDP43. Some people call it as the damn protein, that damn protein TDP43 proteinopathies. Subtypes are there A, B, C, and D. And importantly, amyotrophic lateral sclerosis with FTD is a occurrence that has been described. The tauopathies, as you all know, Pick's disease, corticobasal degeneration, progressive supranuclear palsy. So FTD as frequent as Alzheimer's disease in young onset dementia between 45 to 65 with a prevalence of 20 per 1 lakh, and a diagnosis confirmed by brain biopsy only. So the clinical syndromes, behavioral variant FTD, and can have ALS, and the semantic variant primary progressive aphasia, and non-fluent or logopenic PPA. So all these things are mainly because there are motor disorders, cognitive disorders. You can see the spectrum as the CBS, corticobasal degeneration, PSP, and ALS are motor disorders. The above ones are because the accumulation is same, after tau or TDP protein, and others which are the proteinopathies. So you can see the disparate proteinopathy of frontotemporal dementia, where the clinical symptoms are behavioral disinhibition, apathy, ritualistic, conservative behavior, loss of empathy, hyperorality, and executive impairment. So these are characteristic MRI findings we see. And you see the proteinopathies which we have already discussed. It could be TDP or it could be tau, and because both are to be understood correctly, because we are having more and more treatments which are targeted against tau, they are in clinical trials. And so we'll go on to the last slide about the introduction of these. Disparate proteinopathies can result in clinically indistinguishable FTD syndromes. Mixed pathology is common in AD and Lewy body disease and contributes to clinical features and biomarkers. Protein targeted biomarkers and therapeutics are emerging in clinical practice. That's the reason which why we should know about it. So let's see one case. A 45-year-old presents with 1 year history of cognitive decline, visual hallucinations, delusions, hypersomnia, constipation are the static symptoms. There is a past history of dream enactment behavior typical of REM sleep behavior disorder since 46 years of age and approximately so I mean sorry he is 65 not 45 65 46 of age he had started having this MMSE is 26 by 30 problems with intersecting pentagon drawing. There's mild facial hypomimia and postural tremor. So he's not 45 65-year-old present with 1 year history of cognitive decline and visual hallucinations, delusions, hypersomnia, constipation, orthostatic symptoms. The past history of dream enactment behavior, typical of the for, and the REM sleep behavior disorder type. It's there, and let's see. Yeah. And he's got postural tremor also, right? So this is the case which we'll have to answer. Okay, what is this possibly? And you see the MRI. MRI is not very. Also, there is sight of some atrophy is seen in temporal lobes and nothing specific in this. We look at the FDG PET. Here the blue areas are supposed to be normal and the green is abnormal and the yellow is more abnormal. So you can see that posterior part is involved here, and so FDG PET is abnormal. Okay, now let's see. No, there is a sign in this. This is also FDG PET, but a different sequence, and you can see something. I can give you some idea. That's called island sign, and it's a gray scale of FDG PET, and you can see the DAT scan, which is depicted here. I have flupan or SPECT or a DAT scan, which is shown here. Normally, you see two commas in this basal ganglia region. Donepezil and quetiapine are minimally helpful to this patient. Rapid progression and death within less than 2 years of onset at 61 years. And the age is, I think, slightly confusing, and I made a mess of it. So it is 63, not 65. Okay. So within 2 years, he died. He died in 2 years' time, and we have all those clinical details with you. So, which of the following syndromes is the most appropriate clinical diagnosis? Is it dementia, Alzheimer's dementia, DLB, behavioral variant FTD, PPA?
DLB is more likely, I feel, isn't it? Because
Yeah.
the visual hallucination came,
Ah,
sleep problem came, he was enacting the things,
mm,
and then he had some hypomania like part. So
yes.
dementia with Lewy body is
Ah,
more likely clinically, I'll feel. And
excellent,
then
sir. That's a correct answer. It is as alpha synucleinopathy, and along with REM sleep behavior disorder and idiopathic Parkinson's disease, and so the neocortical Lewy bodies are seen. You can see the body here in one of the diagrams. So this is the Lewy body disease, and McKeith criteria are there nowadays. And this is the alpha synuclein, which is again a misfolded protein, and this alpha synuclein also has got a propensity to spread from one cell to other cell. So core diagnostic features of McKeith in 2017: Parkinsonism, visual hallucinations. The fluctuations are in cognition and are arousal also both, and REM sleep behavior disorder. So excellent. So we'll go on to the second. The consensus criteria: dementia. The core features: two probable, one is possible. Fluctuating cognition, attention, alertness, recurrent visual hallucinations, and these should be formed hallucinations, spontaneous features of Parkinsonism, REM sleep behavior disorder. The indicative biomarkers, that is low dopamine transporter uptake, as you have seen in this case, abnormal MIBG myocardial scintigraphy because the autonomic nervous system involvement, PSG confirmation of RBD, 1 year rule for PDD versus DLB. That means if dementia sets in within 1 year of Parkinsonian features, it's likely to be DLB. If more than 1 year the individual has Parkinsonian features and then develops dementia, it's not it could be Parkinson's disease dementia only. So these are the Molecular alterations in frontal cortex in DLB involve key biochemical pathways such as mitochondria and energy metabolism, protein synthesis, purine metabolism, among others, and are accompanied by discrete innate inflammatory responses. So we can see more and more developments about this. The second case, 60-year-old male presents with history of falls for 4 months and clumsiness over the right arm. He was having features of asymmetric Parkinsonism for last 3 months. On examination, he has got asymmetric Parkinsonism with marked rigidity, high frequency jerky hand tremor, hyperreflexia, right upper limb ideomotor apraxia, but no cortical sensory loss. He is a 60-year-old man who presents with history of falls for about 4 months, and this is the MRI. MRI looks absolutely okay, not very much no abnormality seen, and this is also the FDG PET, which if you can carefully see there may be some abnormalities in the frontal regions, and these are yellow ones are the abnormal areas, and so that
Absolutely.
mild abnormality. And clinical course, levodopa unresponsive, bedbound, dreamlike state, paranoia, visual hallucinations, died after 10 months. So which are the following syndromes the most appropriate clinical diagnosis in this?
It was going, I would felt PSP, I
Uh,
would think, but the point where things are generally symmetric. Here it was a bit asymmetric,
okay.
but false, rigidity, axial,
Hmm.
and these parts were going more in favor of PSP, I will feel.
Would you like to look at the case once again?
Yeah.
And then you make a, now you see. History of
History of
falls for
fall
four
for
months.
4 months, clumsiness of right. So asymmetric is there.
Yeah, asymmetric Parkinsonism with
So
marked
yeah,
rigidity, high frequency jerk,
Parkinson's are there more
and,
likely. High frequency jerky hand tremor, again Parkinson's.
and
But early death,
idiomotor
actually
apraxia.
apraxia and cortical. So cortical
Uh,
basal degeneration.
yes, so that's it. That is the clue to this. It is corticobasal degeneration, and
Yeah.
so the corticobasal degeneration biopsy will reveal pathology on only 40 to 60% in CBD. That's a whole problem with CBD. Even biopsy also will not tell us an answer. So the syndrome is probable corticobasal syndrome, possible corticobasal syndrome, frontal behavioral spatial syndrome, non-fluent or agrammatic variant of primary progressive aphasia, progressive supranuclear palsy syndrome. All these are nowadays clinical phenotypes associated with the pathology of corticobasal degeneration. So there are different criteria given, but the most important is limb rigidity or akinesia, limb dystonia, myoclonus, and apraxias and alien limb phenomenon. If these are things, then we have to look into the corticobasal degeneration angle. 33-year-old presented with personality change and hyper religiosity, apathy, loss of empathy, stubbornness. After 1 year, he developed decreased speech output. Family history of dementia in paternal grandfather, and father developed ALS at 65 years. After 1 year, at for 34 years of age, he was found to be mute with poor comprehension and impulsive. On examination, he was found to have upward gaze restriction. He is a 33-year-old man who presented with personality changes, hyper religiosity, apathy, loss of empathy, and you can see that for a 33-year-old man, the temporal horn is abnormal, and there is atrophy that is seen in frontal regions also and temporal regions. Genetic testing for presenilin 1 and MAPT are negative. Brain biopsy was done at 34 years and it revealed gliosis and ubiquitin positive inclusions. He rapidly progressed and died at 35 years, and 3 years course total. And what are the following? One of the following syndromes is the most appropriate clinical diagnosis for this case. Sir, are you there?
Yeah.
So
I
what do
was
you
just
think?
trying to save.
Uh,
Uh, See, here's a young onset,
mm,
and look at it.
yeah.
First dementia, then eye signs,
Mm,
prefrontal signs are there.
mm.
So we'll put it again.
PSP.
Yeah,
But there are some behavioral problems and the
behavioral problem
ubiquitin,
is the frontal lobe problem is the main thing here.
yes, and the ubiquitin positive things.
and ubiquitin positive. So where do we land up?
So you land up when TDP43, behavioral variant FTD.
Oh my God, you're
So
teaching me all things.
this
Good.
is hexanucleotide. Hexanucleotide repeat
Lovely.
expansion.
Yeah, ubiquitin is there. Yeah.
Yes, ubiquitin. The C9ORF72. This is
Mm-hmm.
nucleotide repeat expansions and chromosome analysis. This case. So this is another variant. It's young age. So TDP43 is becoming another one. The core features of behavioral variant FTD: early behavioral disinhibition. One of the following is a must. That is
Oh,
socially inappropriate behavior, loss of manners or decorum, impulsive, rash or careless actions. Early apathy or inertia, one of the following is a must. Apathy or inertia. Early loss of sympathy or empathy, one of the following is a must. Diminished response to other people's needs and feelings. Diminished social interest, interrelatedness or personal warmth.
yeah,
So these are the early preservative, stereotyped, or compulsive ritualistic behavior. One of the following is a must. Simple
yeah.
repetitive movements, complex, compulsive, or ritualistic behaviors, hyperorality and dietary changes, altered food preferences,
That's the
drinking.
temporal lobe findings. Yeah.
Yeah, and oral exploration or consumption of inedible objects, and there will be executive function deficits, and episodic memory is spared, and visual spatial skills are visually spared. That means neuropsychological profile suggests only executive deficits with relative sparing of memory and visuospatial function. It's a must. So the familial FTLD most often due to a mutation in microtubule associated protein tau MAPT or progranulin PGRN or chromosome 9 open recording reading frame 72C. So these are the three causes for FTLD. The fourth case is we are only a few more cases. 67-year-old lady with no significant family history of neurodegenerative disorder presents with prominent delusions, obsessive compulsive disorder features, and displayed an attitude of could care less about most of the things. The significant positive neurological findings include mild facial masking, a prominent palmomental reflex, and a Hoffman sign. This is a 67-year-old lady with no significant family history of neurodegenerative disorder, presents with prominent delusions,
Delusion, obsessive
obsessive compulsive
compulsive
disorder,
disorder,
and
hyper, see,
yeah, she says
and
she
then the
doesn't care.
facial masking and
Hmm.
palm mentalist reflex means the frontal areas.
Yes, right.
So
So this is the MRI, the in this case,
there are
and
some kids. Even there
and
is some
this you see the green things are supposed to be abnormal. So you
yeah
see the frontal areas
frontal
are
area
involved.
is affected.
Frontal areas is not.
Frontotemporal,
Yeah, possibly.
yeah,
And clinical course and marked apathy at 67 years, disinhibited, disheveled, and frequent falls, obvious Parkinsonism, wide-eyed stare, saccadic pursuits, but vertical eye movements are intact. Died at 62, 2 years course. Again,
yeah,
same. We have to now find out what it is. You have been thinking of PSP for a long time, I think now.
yeah. I will put it there, but where is the things in the mid brain?
Yeah,
That
possibly.
yeah,
The,
where is that
the
bird sign?
Yes, this is the tufted astrocytes and neuropathology of PSP. Tau protein is tauopathy, and
Hmm.
these are neurofibrillary tangles. So the classical syndrome, Parkinsonism, axial rigidity more than appendicular rigidity, frequent falls, vertical gaze palsy, particularly limited to down gaze. These are the updated criteria of 2017 with emphasis on early features. So this is the PSP case. The fifth case, a 70-year-old lady who presented with history of cognitive dysfunction, personality changes, hypersomnolence with fluctuations. There is no family history of any psychiatric disorder. Neurological assessment revealed mild Parkinsonism with an MMSE of 22. Laboratory investigations, CSF normal, anti-TPO is marginally raised. This is an interesting case, sir.
Hashimoto, you are thinking?
It says mild raised anti-TPO, but
Yeah,
we'll see the course.
this
So
goes in the
this is the
uh,
abnormality that is seen in the MRI. Okay,
hmm,
and the patient and family declined brain biopsy. High dose corticosteroids marked improvement. MMSE became
the
29.
Hashimoto's.
remained stable, subtle, mild cognitive inefficiency and mild Parkinsonism for 4 years with no steroids or psychoactive medications. So this is at presentation. This is the MRI. 2 months later, after a 5-day course of methylprednisolone, this is the MRI. That means there is improvement. But what
Is
happened
it?
subsequently? Then suddenly she developed 5 months history of cognitive decline, sudden decline over 2 days, and then died. So she could preserve for 4 years. So whether Hashimoto's can lead to any other. So what do you now? What will we think about this? Which would have
Hashimoto is a very loose term. They
okay?
describe where the TPO was the only one marker they found and the responsiveness to a steroid.
Yes,
And
this lady has responded to steroids. So whether she died of Alzheimer's disease, dementia, DLB, PPA, PSP, posterior cortical atrophy, and CJD. So usually what happens is nowadays the Alzheimer's disease. This is she had along with that amyloid angiopathy. So more and more there are some case series which have come that when you diagnose anti-TPO positivity and Hashimoto's and the steroid responsiveness, they are going into Alzheimer's disease subsequently on follow-up. And these people also may have amyloid angiopathy which will cause the cerebral hemorrhage and death suddenly. So these are the rapidly progressive Alzheimer disease cases mimicking CJD in studies of rapid dementia. These are the case series that have been coming 31 out of 152, 52 out of 2001. You see, these are number of patients with prion diseases, total number of
yeah,
patients. So that means the teaching point or learning point here is that the rapidly progressive AD versus classic AD. Now, what is the difference? The survival rapidly 2 to 3 years, in classic it is 8 to 10 years. Unclear age of onset in the rapidly progressive approximately 73 years, and approximately it is earlier in classic AD. And rate of cognitive decline more than 6 mmsc points per year here. It is approximately 3 to 6 mmsc points per year. Almost same but slightly. Focal neurological signs occur early and they are multiple but they don't occur in classical AD. The CSF biomarkers also very high total tau and p tau levels, very low A beta 142 level and 1433 protein sometimes present. Here high total tau and p tau levels but low levels of amyloid beta 142 and apolipoprotein E genotype with controversial and established as a risk factor for classical. Sir, do you do the tau levels there in your place? In your place,
uh, yeah, it's available.
are
I
you getting
don't.
it done?
I don't do it.
Okay, now I think whenever you get come across rapidly progressive dementias, we can think of doing that. So the
Yeah,
steroid responsive encephalopathy associated with autoimmune thyroiditis, and that is 12 cases of autoimmune thyroiditis which have been studied. They are unresponsive, and some of them developed Alzheimer's disease pathology, and these are the case series. So if they are not improving or they deteriorate, we have to think of Alzheimer's disease along with amyloid angiopathy if they are rapidly progressing and sudden death occurs. That's a learning point in this. 26-year-old lady presents with 18 months history of cognitive and personality changes, maniac behavior, uncontrolled aggression, no family history of any neuropsychiatric disorder. Her total disruptive behavior did not permit any neurological assessment. Routine laboratory tests and CSF reports were within normal limits, and this is the MRI which you can see
caudate is gone, totally flattened out here.
flattened out, and the
The
I
temporal
think
lobe is also gone.
hippocampus is okay.
Both. No, here
Uh,
is this is the
this is here.
ventricular dilatation here.
Uh,
Hippocampus is also gone.
Here,
Fine. Temporal lobe is also gone. Is a
there's atrophy.
diffuse,
Yeah,
but the
diffuse.
caudate is especially flattened out.
Yes. So what do you think, sir?
Is a young any family history of Huntington's?
No. You can see 18
Yeah,
months history of cognitive and personality changes,
18
behavior change.
months.
There was no family history of any neuropsychiatric disorder.
Yeah.
So we have this complicated case, and the MRI is like this. There is
The,
again, you have wasting of
the
temporal lobes and frontal lobes. You
midbrain
can
is
see
very
the
shrunken.
PET.
Yeah.
The PET is showing global. It's everywhere. Abnormality is everywhere. The blue things are normal. The green and the
Green,
yellow are abnormal. So you can
frontal,
see it.
temporal, parietal, all is
All places it is
global.
yeah, visible. So what is the diagnosis and how will you investigate? This is the last case because here the patient's relations refused biopsy. So
Any
the
postmortem done?
no, this is a case which is in the literature,
Okay.
not postmortem, and they did a next generation sequencing, the whole genome sequencing, and
Hmm.
they found out the MATR3 mutation, which is which will a disease protein linked to amyotrophic lateral sclerosis and frontotemporal dementia. This exome sequencing with mutations in MATR3 is also seen in ALS. So
Matter three.
nothing much is known. It is published, but such very vague cases also will bother us. How about you? So what will you do there in such type of cases? Do you do genetic testing, next generation sequencing, or whole genome sequencing there?
No, I don't do. We don't handle this.
Okay.
See, mine is a absolutely general neurology clinic.
Yeah.
So we don't go for this research-oriented thing. Like, say, I'll tell you, one patient has come from UK,
Mm.
had a bone transplant,
Mm.
and in the bone transplant, they use animal bone.
Okay.
Bovine bone was implanted on him
Oh ho.
in the vertebra,
Oh. Okay.
and then he developed dementia.
Oh.
And I
Okay.
had suspected the variant CJD,
Ah.
fine,
Yes. Yeah.
but he had myoclonus, he had some kinesia, like say
Mm.
alien hand-like things. Like
Mm.
remember, we had one colonel admitted in the ICU of
Yeah. Yeah.
Pune
Yes. Yes. Yes.
where we suspected it.
Yes.
But
That's
then
true.
we don't go any further than that here.
Okay.
We lose him after 2 years of continuous illness, A, B, C, D,
But
like that.
as we know, the variant CJD, people live longer. Median life is about 1.5 years and more, median life. That
Yeah.
means they can live longer also. The summary of rapidly progressive dementia, often early onset, subacute to chronic encephalopathy, no significant family history, but always question of family history of dementia, Parkinsonism, and ALS to be asked. All non-degenerative etiologies, including CJD and autoimmune encephalopathies, have to be ruled out. And FTLD spectrum disorder, DLB, PSP, CBD, and AD are the most common degenerative etiologies. Some cases may have multiple etiologies, like we saw cerebral hemorrhage also. And these are the proteinopathies, that is, AD is beta amyloid and tau, and alpha synuclein for Lewy body disease, tau, TDP43, and FUS for FTLD, and CBD tau and PSP tau. These are very important proteinopathies for which research is actively searching for treatments and targeted therapies. So the management is a thorough laboratory assessment, MRI with FLAIR and DWI. This is the learning which we did in this class, no, sir. We don't look for
Yeah.
1433 anymore.
Yeah.
And EG, CSF exam always include IgG index synthesis, oligoclonal bands, and of course AB and amyloid beta and tau. And the amyloid beta will be low and tau will be high. Consider genetic testing even if family history is negative. Consider FDG PET imaging. Consider isoflupine SPECT, that is DAT scan, and amyloid PET and tau PET imaging if available, and meningeal and brain biopsy. So symptomatic treatment, acetylcholine esterase inhibitors, SSRIs, atypical neuroleptics, empirical trial of corticosteroids reasonable in some cases where the methylprednisolone for 5 days, 1 gram per day, and once a weekly for 6 weeks. If no striking improvement within 4 weeks, highly suggestive of degenerative or a prion disease. So that's a guideline which we can follow. And the controversies or empirical trial of medications may be reasonable in many circumstances. Which medication should be used and for how long? The response to steroids or lack thereof is often used to differentiate an autoimmune inflammatory process from another incurable process like degenerative prion or paraneoplastic. But some cases may have elements of two or more processes of at play. So that's all from the Neuro E Patsala on this Friday, and we discussed about rapidly progressive dementia, and some of the controversies and causes. And thank you, Sinha sir, for your active participation. We hope to see you
Thank you
more.
very much.
We hope to see you more often.
Yeah.
And I'll just come back on the line, telephone line. Okay, sir. Jai
Thank
Hind.
you very much, Gorthi. It was very nice and educative presentation. It revised a lot of things for me.
Yeah, thank you,
Normally,
sir.
one doesn't get time to read so many things.
Yes, yes.
Right?
That's what
Thank
it
you.
makes it. It's
Yeah.
a lifelong
Thank you.
learning, sir.
Yeah.
Right, sir.
Thank you very